All right, hey guys, this is Nick. Hopefully, you're just illuminated by Kevin talking about more of the pathophysiology of seizures, some of the more specific conditions, and I'm now going to talk about anti-seizure drugs. So, some of the drugs we use. I'm not necessarily going to cover for this condition use this drug type thing. More just a general approach, a general understanding of the medications. Just since there are quite a few of them, and it can get a little confusing. So. Hopefully just getting that general information down, and then that can help. So learning objectives provide effective management for seizure patients. I think we will be better along that path with a better understanding of the drugs. I'm also saying up front, I've shamelessly included pictures of my baby because that's a big thing going on right now. So this is him, the first ever picture taken of him, just a few minutes after his emergency C-section. 3 pounds, 7 ounces. Lots of pink. All right, so the goals of anti-seizure therapy are kind of threefold. So the three main goals, I guess you would say. So the first is to control the seizures. Keep them from occurring, keep them from coming back. That's one of the main goals we want to do. Another goal is to minimize side effects. And the interesting thing is you might put a patient on a drug that controls the seizures well, but if they're having major side effects, that's not going to work. And vice versa. You might have a drug that they don't really have good side effects, but if you're not controlling the seizures, it doesn't work. So it's important to realize that it can actually fail for either one of those reasons. And it's actually very common to fail for side effects, or just as common to fail for side effects as it is for a lack of controlling the seizures. And the third is to maintain or restore quality of life. That's what really the goal what we're wanting to do is make life better for them. So just some other basic points. The initial treatment, you want to start with just one. If at all possible, avoiding polypharmacy is the best. And for a lot of people that won't work, but that's where you want to start. And there are over 20 anti-seizure medications to date. None has been proven to be more efficacious than the other. I thought that was interesting. That also makes it a little bit more difficult in terms of starting, because you can't just say, oh, patient comes in, doesn't matter who they are, start them on this drug. You kind of have to have a good understanding of a lot of the other factors, which we will go into in just a minute. So a big question that we ask is, when do we want to start these anti-seizure medications? The official recommendation is you want to start them after 2 or more unprovoked seizures. So without a real clear cause, 2 seizures, that's when you would want to start them. In certain situations, it might be better to start them earlier. For example, if there's a potential symptomatic cause of it, like a tumor, a stroke, some trauma. If they have epileptiform features on an EEG, then it's probably better to prophylactically treat them. If there's an abnormality on neuroimaging, such as CT or MRI, you might want to start them earlier. And if there's an abnormal neuro exam. So those are all reasons why you might consider starting them, but those aren't concrete reasons. It's not like if they come in and they have that, it's for sure, but those are ones where you would definitely consider starting them earlier than the 2 unprovoked. So here we go with mechanisms of action. I'm not going to kill you with all the details or anything like that. This is actually, all I'm going to do is just give you this chart just to have a kind of 30,000 foot view of it. So you have sodium channel, calcium channel, GABAergic drugs, glutamate, carbonic anhydrase inhibitors, and then other. So I'll send this PowerPoint out. You'll have access to this chart. You could probably find prettier charts other places. I just thought this was helpful to kind of break it down a little bit, just to have a basic understanding of what the different drugs do. So you have, I could read them all, but you have this chart. I'll send it out. So yeah, nothing more to really say about that. So then there's how to decide which drug to use. There are some major considerations. We're going to go through 4 major considerations in pretty good detail. So first consideration is, what type of epilepsy does the patient have? Is it focal? Is it generalized? Absence? Then there are potential side effects to take into account. Then there's other prescribed medications the patient may be on, that whatever, you know what I'm saying. Those drugs might interact with, and then we have comorbidities. And we'll go into those, and then we'll just briefly touch on a few other considerations, but the main thing I wanted to touch on were those 4 considerations. So this is another picture of Dempsey, still from his first day of life. So you want to determine which type of seizure the patient has. And a lot of that I'm sure Kevin has already covered. But from the drugs perspective, you have broad spectrum drugs, which can treat both focal and generalized disorders, and then you have more narrow spectrum, which can which focus more on the focal onset disorders. And then there's another narrow spectrum specifically for absence seizures. So a main point I wanted to make with this is that, so what can happen is with the narrow spectrum drugs, they can be really good if you know exactly, for example, where the seizure is occurring. For example, one good example that I found was you might have a patient with temporal lobe epilepsy, and gabapentin may work really well for that. But then gabapentin might not be helpful in a different type of epilepsy, or a myoclonic epilepsy. So really these narrow onset drugs, they're really good for the specific things. But if somebody comes in with epilepsy that you don't have a good understanding of, or you don't have a good diagnosis or a specific diagnosis, or knowing that it's focal, you wouldn't want to start them on a narrow spectrum drug. You'd want to start them on a broad spectrum drug. And actually there have been some narrow spectrum drugs such as oxcarbazepine, carbamazepine, phenytoin, vibagatrin, and gabapentin that have actually been found to worsen certain seizure types in generalized epilepsy syndromes, so that you can actually do more harm by starting them on the wrong medication. So this is another chart that I'll send out that you'll have access to. I think this is a good one just to generally know which ones are broad spectrum and which ones are narrow spectrum. And then another, there's absence seizures, which I'll talk about just a little bit later as well, just very briefly. But yeah, just knowing, we want to, if you're not sure if it's focal or generalized, start them on a broad spectrum. If you know focal and you have a good idea of where it is, then that would be more a situation where it would be good to start on a narrow spectrum drug. Another very important thing to take into account is the side effect profile, because with these anti-epileptic drugs, they do have significant side effects. So first we have neurocognitive side effects. The older drugs in general are the worst. So drugs like phenobarbital, valproate, carbamazepine, and phenytoin. Phenobarbital is the worst, but they all have significant neurocognitive side effects. So that's something to keep in mind. And then among the newer drugs, topiramate and oxcarbazepine have some of the worst side effects, and gabapentin and lamotrigine have relatively fewer side effects. And then we have hypersensitivity reactions. So there's Stevens-Johnson syndrome and toxic epidermic necrolysis. So those are dermatologic reactions, and especially they're bad ones. So they're scary ones. And so those are associated with carbamazepine, oxcarbazepine, phenytoin, lamotrigine, and phenobarbital. And then less commonly valproate and topiramate. The important thing to realize is all of the anti-epileptic drugs have been described with these hypersensitivity reactions, but for those specific drugs it's worse. So the main thing that you want to pay attention to is in the first 2 months. That's when it's most likely, this reaction is most likely to occur. So make sure patients are aware of it, and make sure they're on the lookout for those symptoms so they can let you know if they have them right away. And then there's also a higher risk with carbamazepine and possibly phenytoin in patients with the HLA alleles of B1502 or A3101. So the FDA actually recommends HLA testing prior to starting carbamazepine and maybe phenytoin. So other side effects, you have suicidality. Obviously that's a major side effect. The rate is, some studies show that the rate is 2 times greater among patients on these drugs, or on drugs of this drug class, than the general population. So that's significant. So it's recommended that screening occur for depression at diagnosis and when they're started on these drugs, and then also at every following appointment. So whether you're a neurologist or not, this is something to be aware of, to be screening these patients if you know that they're on these drugs. Be aware of that correlation and screen for it, because that's something that we as doctors can try and prevent from happening. Try and prevent those high rates. And then weight gain, weight loss. No one likes weight gain. Or some people don't like weight loss, I guess. But you have gain, more drugs cause gain. So valproate, gabapentin, carbamazepine, vigabatrin, and pregabalin. And then loss are those three: felbamate, topiramate, and zonisamide. So just be aware there are some weight side effects as well with these drugs. And then another consideration is drug-drug interactions. The main ones to consider are hepatic enzyme inducers and inhibitors. So going back to kind of a lot of those step 1 questions, inducing drugs to be metabolized quicker or inhibiting them, raising their levels in the blood. So in terms, more of them are inducers than inhibitors. So in terms of inducers, the three of the older, the phenytoin, phenobarbital, and carbamazepine, and then a few of the newer as well, are associated or are known to be inducers. And then the drugs that they induce are actually pretty common ones, such as statins, calcium channel blockers, SSRIs, antipsychotics, tricyclic antidepressants, hormonal contraceptives, warfarin, anti-cancer drugs. A lot of these are common drugs that we probably see patients on in clinic every day. And so it's important to be aware that if they're on some of these anti-epileptics, they can be interacting with these drugs and making them less efficient. And a classic example is phenytoin induces warfarin metabolism, so you'd want to look at the INR to see if it becomes subtherapeutic and maybe raise the dose of warfarin. And then the one inhibitor to remember is valproate, so that can just increase the concentration of other meds. And then comorbidities. So we'll start with renal disease. You have a few of the drugs that are renally excreted. There's gabapentin, topiramate, zonisamide, lacosamide, and levetiracetam. So you need to lower doses of these drugs in patients with renal disease because you don't want to cause more renal damage. And then if patients have albuminuria, you may need to decrease the dose as well. And then 2 drugs, topiramate and zonisamide, are actually associated with nephrolithiasis. So if a patient has a past medical history of kidney stones, then you'll want to avoid these drugs. And then hepatic disease is kind of the bigger one because pretty much most of these anti-seizure drugs are metabolized in some part by the liver. So you should be dosing them with caution in the presence of liver disease. And then there are a few that are actually cause liver toxicity and should be avoided. So that's valproate, felbamate, phenytoin, and carbamazepine. So you just want to keep that in mind. Don't start patients with liver disease on those drugs. And then another comorbidity are migraines. And then this is actually a good thing. Some of the anti-epileptics have actually proven to treat migraines effectively. So you can avoid polypharmacy with them. So valproate, gabapentin, and topiramate, you can kind of kill 2 birds with 1 stone there. Then we have psychiatric disorders. So epileptic patients have a disproportionately higher rate or prevalence of comorbid psych disorders. So that's important to be aware of. Certain drugs are actually have mood stabilizing ability, can be used in bipolar or anxiety and depression. So those are those 4 right there: valproate, lamotrigine, carbamazepine, and oxcarbazepine. But this doesn't substitute for a formal psych evaluation, so they should still be getting their formal psych evaluation. And then other drugs can actually potentiate depression or precipitate depression. So the GABA potentiators like valproate, lamotrigine, and topiramate. And then other drugs that can actually cause psychosis. So levetiracetam, topiramate, zonisamide, and ethosuximide. So these are all just things to be aware of. These are details that you don't necessarily have to memorize, but just be aware of them. If a patient needs to be started on one of these, keep these things in mind. The last is osteoporosis. The anti-epileptics are known to be associated with bone loss. And when you combine that with the fact that you have these patients who are having seizures and falling, that can be bad, more prone to fractures and bad outcomes. So the only drug to completely avoid is phenytoin. That's the only one that's completely contraindicated. But when they're on these medications, it's important to monitor things like bone density, get them on calcium and vitamin D supplementation, and emphasize regular exercise so that they can avoid, hopefully, some of those fractures or bad outcomes. This is our first family picture, and I included it because we were about to talk about women of childbearing age or in pregnancy. So all women of childbearing age on these antiepileptics should be on folate supplementation. There are two drugs where they need to be on a relatively high dose of 4 milligrams per day, and that's valproate or carbamazepine. And then for all the other drugs, it can just be on 0.4 to 0.8 milligrams per day. Something else to keep in mind is that there's an increase in contraceptive failure rate from 0.7 to 3.1. And then there's pregnancy. In pregnancy, the overall risk of fetal malformations is 4 to 6%. Valproate is a major contributor, and it's the only specific drug to be avoided if possible. And then other big things are try and avoid polypharmacy in pregnancy, and try and avoid use early on in pregnancy if possible, because those are associated with an increased risk. And then we have the elderly. So generally the approach is the same, kind of what we talked about all up till now. The approach is the same, just even more important in the elderly. And some differences are that the newer drugs are actually recommended in the elderly over some of the older drugs because they have fewer side effects, fewer drug interactions, and better pharmacokinetics. So drugs like levetiracetam, lamotrigine, and gabapentin are going to be better for the older people. Then you have vitamin D and calcium supplementation, like we just talked about. That's even more important in the elderly, and then also frequent monitoring of their bone density. And driving should be restricted in them. That's a cute picture, one of my favorites. And then there is absence seizures. Dr. Pre wanted me to just add a little snippet about this. I don't know if it would be covered in the pediatric section or not, but it's a frequently tested topic on board examinations. First-line treatment is ethosuximide. If that fails, then valproate is the next best choice, and you would stop the ethosuximide. Or if you're treating them for the absence seizures and they begin to have general tonic-clonic seizures, then the best drug to add would be valproate. So you'd continue the ethosuximide and add valproate. So in summary, I know this has been long and it's been torturous, and I apologize for that. But just remember, no one drug is more efficacious than the other. When you're trying to decide what drug to use, you want to look at the patient individually. There's no one drug fits all. You need to take into account what type of epilepsy they have. You need to take into account how those side effects would affect them, what comorbidities they have, and possible drug interactions for the drugs they're currently taking, and use that to kind of shape and guide what drug you want to start them on. Remember that an incorrect use of a narrow spectrum drug can actually make the symptoms worse. It can make the epilepsy worse. Remember that the approach to pregnant women of childbearing age, and elderly is a little bit different than the general population. There's just a few considerations to remember there. And also remember that therapy is just as likely to fail due to intolerable side effects as failure to resolve the seizure symptoms. So I think just knowing generally having some of these drugs in your tool belt, knowing a little bit about them, and being flexible, being ready, able to switch from one to the other if need be, is important, and also very applicable to real life, because a lot of these patients will end up having bad side effects or won't treat the seizures. So I included some common side effects of the anti-seizure drugs and rare but serious side effects of the anti-seizure drugs, just as kind of a summary. I'm not going to go over this right now. I promise I won't torture you more, but those are just things that you'll have because I'll send this out and they're helpful. And then we'll end with this one because this is a picture of when Dempsey finally graduated from the isolette to the crib and got to start wearing clothes and instantly became a lot cuter and more human looking. So thank you very much for your time. I appreciate it, and I hope this was helpful. Hope it'll be helpful for the cases on Friday, and we will see you all then. Thanks.